This is our third sports medicine research rundown, and we are totally honored to have Dr. Mark Zoland, a world-renowned general surgeon. Is that correct? Who specializes?
I'm a general surgeon, yeah.
Who
World-renowned, I don't know.
who specializes in the subject we're going to talk about today. Tell us about yourself. Where did you train? I know I've met you at Lennoxville Hospital 30 years ago, but certainly, did you train at Lennoxville Hospital or?
Yeah, so I was at undergrad at Columbia, med school was at Cornell, and then I did my general surgery at Lennoxville. And the great part about that was, doing general surgery, we were kind of tied in with a lot of the orthopedic stuff going on. And as you well know, Steve Nicholas was kind of the first guy that ever said to me back in 1999, I need you to do a sports hernia repair. And I said, a what? And he said, a sports hernia. And I had no idea what that was. I researched it. I did a repair. And it was on a former NFL punter who wanted to just be able to play basketball with his kids. And it actually worked really well. And the crazy thing was I had no idea what I did that helped him. So I had to go deep, and that's where it all stared. And
Wow,
that's why I always give Steve credit for that, just pushing me into it.
that's awesome. And now we can't say names, but you've done some of the most famous hockey player, golfers, and professional athletes out there. So
I've done a
great job.
few, yeah, high
Yeah,
level
yeah, yeah.
people, yeah,
You can be humble. It's okay.
yeah.
It's great. But what are you really doing? If we get started, you said you did a sports hernia. Then it's been called sports hernia. It's been called athletic pubalgia. That's what it's called now. It's been called Gilmore's groin, sportsman hernia, posterior
Right,
wall, the inguinal canal, a groin strain, a pubic plate injury.
right,
The article we're going to talk about now is the rectus abdominis-adductor longus aponeurotic plate injury repair that you sent me just this week. Okay,
right.
and you're the one that kind of educated me on what this is and how you repair it and that sort of nature. So, take us through a little bit of that history, if you would.
Sure. So back in the 80s, there was a guy named Otis J. Gilmore who was treating rugby players and soccer players in England and Australia. And the issue was that these athletes, these very, very rugged, strong, powerful athletes, were coming in with groin pain. And the interesting thing about it was, for all the world, it seemed like there was a hernia, but on physical exam there was no hernia. And the hernia, just for those of you who don't know, I'm sure most of you do, is an opening in the inguinal canal, or it could be anywhere in the abdominal wall, but this specific hernia that we're talking about is the inguinal canal down in the groin. And it's an opening where the inguinal canal has not closed down appropriately after the testicle has moved down to the scrotum, or in the female, the round ligament has attached to the labia, and the opening allows either bowel or fatty tissue or some other organ to protrude through. However, on physical exam, that's usually a pretty clear exam that you can see something protruding through or feel something protruding through. On these players, there was no hernia. There was no actual defect where something was pushing through to any degree that anybody could see or could tell on physical exam. And yet they were becoming incapacitated. They weren't able to play. They had pain in the groin area where a hernia should have been, but wasn't. So what he did was he did a surgery, and this is back in the 80s. So, and it was in England, and they just go crazy over there. They do, surgery on things that are just, experimental, let's say, and they didn't worry too much about the legality of it. And the fact is, he found at that time that on a lot of these players, there was a bulging of the inguinal floor, what is also known as the transversalis fascia. And the bulging was, he felt what was causing the pain syndrome. So he closed down the inguinal floor by pulling one structure called the conjoint tendon down to the other structure, the inguinal ligament, and flattened out the inguinal floor. And in a lot of these players, that actually worked very, very well. And that became known as the Gilmore's groin. And technically, what that is a bulging forward of the inguinal floor, but it wasn't an opening, and therefore it wasn't technically a hernia. So that being said, the the surgery that he did helped a lot of these players, but it didn't help all of them. So over the period from the 80s to the 90s, there was this construct that maybe it wasn't just the inguinal floor, and specifically a lot of players were coming in with adductor pain, and therefore the attention was shifted not just to the inguinal floor, but also to starting to understand that it was more about an attachment issue at the pubis. And as the MRI technology became better and the information that we got was able to be correlated with what we saw on the imaging as injury to the adductor or injury to the structures at the pubic attachment point, aka the aponeurotic plate or the anterior pubic ligament, or some people call it the aponeurotic complex. The simple fact is, it wasn't just about the inguinal floor, it was about the attachments at the pubis in addition. And therefore, it's become a bigger understanding of the structures that are injured, and therefore our understanding of what to do for the injury has become a lot more integrated into our our surgical maneuvers.
Is this in the paper we're going to review tonight? They provided MRI, two MRIs there,
Yep.
and we could see fluid in there on the imaging. Is this
Yep.
something that you see often? And you're like, what is your signs and symptoms of a pubic plate aponeurotic plate injury? And then how do you decipher that from some of the other clinical entities that we went through in the Doha agreement? Adductor related strains, iliopsoas related strains, posterior floor of the inguinal canal uh, defect or bulge, which presses on the nerve, and pubic pain. What's your algorithm? How do you go through making that pubic plate diagnosis?
Right. So, for me, there's two components, and I think this has been sort of the culmination, quite nicely, of the evolution of understanding the MRIs. The physical exam is almost always somewhat instructive to understand that there's an adductor component, and all of you have seen this adductor component on your patients, I'm sure. And then you add that to the MRI, and the MRI, indeed, just what you're referring to, Tim, has either a fluid level or what we call intermediate signal, or at the very least, a little bit of bone marrow edema in the pubic body. And what that is showing us is that there's an injury around that pubic area. And the injury, the reason why Doha broke it down, and quite well, by the way, they really sort of are breaking it down into the different structures. The reason why that holds fairly well is because the MRI shows us that there is either a pubic attachment injury, and the pubic attachment injury could be the aponeurotic plate. It could just be lower down at the adductor fibrocartilage, or it could be this combination of adductor, fibrocartilage, aponeurotic plate, and it could be the inguinal canal. We developed a protocol for the MRI in order to, number one, elucidate that injury, and that wasn't our. I can't claim credit by any stretch for that information. That was done by Bill Myers down in Philadelphia and Adam Zoga. So shout out to them for coming up with this aponeurotic plate injury construct. Ta- uh, Ernest Childers out in London started going very deep into the adductor fibrocartilage disruption part of the injury, which we can get into. But what we did do is we developed the pubalgia protocol, which delineated the inguinal floor component of the issue. And
Okay.
what we found during this MRI protocol, which was looking at all these things, by the way, so it was a perfect diagnostic study for this injury. We had people doing a Val-Salva during a quick sequence, T1 fat sensitive, um, axial image to see if the inguinal floor was bulging forward. And what we found was that the inguinal floor bulging forward, consistent with the Gilmore's groin or that original
Hmm.
sportsman's groin injury, happens about 35% of the time when you have the aponeurotic plate injury. So that 35% of the time is not coincidental. It's too high of a number for it to be just coincidence. So what we sort of come to this conclusion indirectly. I mean, you can't prove it scientifically, but with the correlation, we feel that either an inguinal hernia or the Gilmore's groin does cause a fair degree of vector force or change in the vector force at the pubis. So when you have somebody with an inguinal hernia or a Gilmore's groin and they're a high level athlete, everything that's even slightly abnormal, like the Gilmore's groin or an inguinal hernia, in and of itself may not be a pain generator, but it could cause different vector forces at the pubis and ultimately cause the injury at the pubis. And that
Right.
injury at the pubis being the aponeurotic plate injury, which is a little bit higher up, or the adductor fibrocartilage injury, which is a little bit lower down, or a combination of both.
What about the rectus abdominis fibrocartilage injury? Is that, you see that
So
also?
right. So the rectus abdominis, where it's going to insert on the aponeurotic plate, is that aponeurotic plate injury. There's no fibrocartilage for the rectus
Okay.
tendon insertion. What happens there is that the tendon comes, if this is the bone, tendon comes in front of the bone and inserts just at the bottom of the bone, and then lower down the adductor fibrocartilage is right here. And they're slightly offset. If you're looking at it anterior to posterior, one is here and one is here, but it's all part of a structure called the aponeurotic plate or the prepubic aponeurotic complex.
And you explained to me last year that that kind of gets lifted off itself. It
That's
gets
right.
lifted off the pubic bone. And Dr. Myers when explained to me also, it's like a baseball. A baseball has that sheath over it, that covering, that
Right.
leather
The
covering,
leather,
if
the
you will.
leather covering over the hard ball underneath.
Yes,
Yeah,
and that gets lifted. That's kind of how he explained it, and I understand
that's
that.
right.
Now,
Yeah,
now, when that is lifted off, and sometimes it's lifted off, sometimes it's strained, sometimes it's detached. Right
right.
now, do you do you think non-operative physical therapy and treatment can help that? Do you think PRP can help that? What's your thought on that first before we start talking about repairing that?
Right. So when we did our study back in 2014, what we found was that all comers who have that injury proven by MRI findings, if you wait it out for about 6 months, and 6 months is arbitrary, it could be 4 months, it could be 8 months, whatever it is, but if you give it a period of time of rest, what we found was that about 30 to 40% of people will get better on their own. And then there's the physical therapy component we'll get into in a second, but it's an important point. Anybody that has this injury isn't it's not a fait accompli that they need the surgery. The question will become if they well, number one, if it's a professional athlete, they can't really wait for 6 months to find out if they're one of the 40% that is going to get better. So that that level of athlete, generally you go ahead and you fix right away because they don't have a time frame to wait for the next season. But in your other patients, can they wait it out? Can they do a period of rest and then start a period of physical therapy? And will they get better on their own? And 40% of the time, 30 to 40% of the time, you will see people getting better without doing the surgery. Once they've reached whatever the time period is, and again, we used 6 months in our study, it is a little bit arbitrary, but what we found was that when it goes beyond 6 months, people hit what I call the plateau. And what happens is they get better, 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 and then they kind of reach this plateau where they're at about 70%, 80%, but they don't go beyond that. And then the question is, do you want to live on the plateau? Is it okay to live with this chronic injury? It acts up sometimes, just like other chronic injuries do. Do you want to live with it? If it's somebody who feels like, you know what, I'm not happy on the plateau, I'm not happy living with the chronic injury, then you go ahead and you repair them. In repairing them, what we found was that about 90 to 93% of people had a successful outcome. Now, again, not everybody wants to wait. There's a lot of, recreational athletes who are like, I'm not waiting 6 months just to find out if I'm one of the 40% that is going to get better.
Are,
I want
are
surgery. But to your point, there's other options. You can try the PRP,
Mhm.
you can try stem cells. Um, the question is, do those work? And the short answer is we have no idea.
Right.
In my practice, I do PRP just because I want to offer it as an option, a non-surgical option. Um, the problem is you force people to rest after you do the injection. Are they getting better because of the injection, or are they getting better because of rest? And the short answer is we don't know. Um,
How long do you force them to rest, and do you send them to therapy? Do you force them to rest a day or two, or you send them to therapy? Say start back with therapy after a week. And are there any Dr. Zoland clinical pearls or words of wisdom that you can say, hey, you know what, this person should do well with non-operative treatment?
right. So, um, okay, so there's a lot packed into that question.
Yeah,
So,
there is.
um, so you do the PRP, and the way I look at it is you give them a month, right? You give them a month of rest, and then if they've improved, with the PRP, start some physical therapy. And if they've improved and yet they still feel like there's some ways to go, give them another PRP injection. So you can give up to as many as you want, but my feeling is if you've given 3 PRP injections and they're not there, don't waste your money, don't waste your time. You know what I
Right.
mean? But
Yes.
if they're improving, try another PRP injection, see where it goes. Give it, and the way I do it is PRP, rest for a week, start some physical therapy, see where it goes. One major point, Tim, and you know this, but I want to put it out there for everybody.
Yeah.
If you, and this is, let's call it a pearl. I don't know. I'm curious to know how you guys all feel, but my feeling is when you're doing physical therapy, the thing that you don't want to do is really work the adductor and the lower abs particularly hard. Sorry, my computer keeps going on and off.
All right.
You don't want to work the abs and the adductor hard, because what's the point? If we're looking at this construct of this is the bone, this is the aponeurotic plate, here's the adductor. If you have some degree of injury, why cause tension on the area that you're looking for it to heal? So what's the physical therapy? To me, it's about dispersing load. You want to work. So if you think the injury is anterior chain and medial chain, you want to work lateral chain and posterior chain.
Posterior.
You don't want to work adductor. You don't want to work abs. In fact, it's my feeling, and again, I can't really prove this with research, but it's my feeling that sometimes if a trainer says, "Oh, you have an adductor injury, and you know what? You have weak adductors. We're gonna work that adductor," they force a patient who has a potential chance of healing on their own into having surgery because they didn't let the adductor actually heal. So the worry would be that you're actually causing injury or not letting an injury that was, an acute injury heal, and you're forcing it to become a chronic injury. So it's really important, I think, that people understand that it's not about adductor weakness, it's about adductor overstrength, right? The vector force on that pubis is extremely powerful to pull it off. And think about it for 1 second. Hockey players, soccer players, lacrosse players, none of those people who have been playing those sports since they were 4 years old have weak adductors. It's the opposite. They're all too adductor centric. They pull on the adductor vector way too much. And that therein is the injury. So you don't want to work the adductor. You want to teach them how to disperse load better. You want to use the other chains in that area. You want to use lateral and posterior chain. So, I mean, again, I can't say to you this is research information. It's not. There's no way for me to prove this, but if you're asking me conceptually, the way I see this, from a PT perspective, that's
Mhm.
the PT perspective.
No, it's the same PT perspective that I was taught by Vladimir Yanda. And, medicine is limited by what we can measure. Okay. And we can't measure everything, unfortunately, but there are things we do that have the best possible evidence. And that's excellent explanation you gave us there. When you do go and repair that pubic plate, Is it a big incision? Is it arthroscopic? Is it do you use multiple suture anchors? How do you do your repair? Well, we're going to go over in a second this article for a little bit and talk about how they repaired it and their post-operative guidelines. But talk about how you repair yours, Doc. Is it open procedure? Is it arthroscopic? Thank you, Dr. Zoll.
Sure. So I do laparoscopic hernias all the time, and that's for inguinal hernias. But for this, you cannot get to this spot laparoscopically. It's not an arthroscopic repair that one can do because it's on the front of the pubic bone. If this is the pubic bone and this is the plate, and we're operating laparoscopically, we are behind the pubic bone. We cannot get to this spot. Some people have written articles about putting a mesh all the way across back here, and this construct is that it will secure the aponeurotic plate better. It doesn't. There's no way that putting something back here can secure this. Now, I do think that there's some legitimate constructs for putting a mesh posteriorly, laparoscopically, if you have a Gilmore's groin or a hernia, but I don't think you're really going to get much on the aponeurotic plate or the adductor fibrocartilage. So what I do is, and again, I'm a guy who does laparoscopic hernias all the time. If I could repair this laparoscopically, I absolutely would. But conceptually, I just don't see it. Mechanically, it just doesn't fly for me that you can repair this structure on the front. So what I do is, if it's just an aponeurotic plate injury, I'm going to use sutures going through the plate into, and again, the plate is a fascial structure. It's this coalescence of all these different structures: rectus, inguinal ligament, adductor, and conjoint tendon are all coalescing on this structure called the aponeurotic plate. So I'm putting sutures through the plate, through the periosteum, and tying this down. So whatever's going on here becomes secure. Alternatively, if it's a fibrocartilage injury, which is this sort of very powerful triangular structure on the underside of the pubic bone,
Mm-hmm.
attached to the adductor, and that is off, then we use anchors. So what we do is we put 4 different anchors, if we can get the footprint that's large enough, and we put them into the bone, and then we bring up the fibrocartilage to that spot, and then we repair the plate. Because technically and conceptually, you can't really have a fibrocartilage injury that does not disrupt the plate. But if you just have a plate injury, we don't need to use the anchors because this fibrocartilage is oftentimes intact. So, and this is going back to our original point, the MRI is fabulous for this. The MRI will give us this indicator of, is it just a plate injury, or is it a plate and a fibrocartilage injury, or is it only a fibrocartilage injury? But nonetheless, we still have to repair fibrocartilage and then plate. So, and then of course, going back to the original point, or is it inguinal canal bulging
Yep.
forward
Yep.
and it doesn't have anything to do with the plate, you know? So the beauty of the MRI is it gives us now, within a very good sense, the degree of injury. The only time the degree of injury gets lost on the MRI is if a lot of time has gone by between the injury and when we're doing the MRI. So, for example, if you have somebody 3 years ago who had the injury, fluid is what we're looking for. Over time, you can have a tear, but the fluid that would normally express that tear has been absorbed by the body. So ultimately, you don't necessarily have to have fluid if it's further down the road. So that's where the clinical exam or the history really become very, very important.
Okay.
Does that make sense?
And that makes a lot of sense to me. It was a little difficult for me to comprehend that concept at first, but as you explain to me more and more, I'm getting a better understanding of it. There are cases where you're in the OR with a hip surgeon too, where you might be doing an FAI a with a aponeurotic plate repair. Correct?
Right. We try not to do those operations simultaneously. Some people do them simultaneously, but their recoveries are a little bit at odds with each other, unfortunately. So, and then the other part of that point is that during the arthroscopic hip surgery, you pump a lot of fluid into the area. in some studies, there's 2 liters of fluid that literally go into the soft tissues. So I don't love the idea of operating when there's been so much
Okay.
fluid. Then, so what we normally do is we stage it these days because the hip surgery has a 6 month recovery usually. The aponeurotic plate injury surgery has a 3 month recovery. So we'll do the hip, and a couple months later we'll go ahead and we'll do the aponeurotic plate, so that hopefully those injuries come out at around the same time. By the way, Tim, I don't know if you can see, Rob has a question. Um,
Just yeah, for you, I'm just
that's
curious.
okay.
Hey, Tim, just
Yeah, Rob Donis. I mean, we're almost ready to go to the article, so
perfect.
go to question.
So any robotics in this? Are we getting to that point, or is it not worth?
Well, the problem is, again, you don't have a space to work within from a robotic perspective. So laparoscopic and robotic would be the same approach. It's just one is plugging the instruments into the robot, and laparoscopic is just me working the instruments by with my hands. But you can't get to that spot robotically or laparoscopically right now.
Okay. Any other quick thing? So a posterior wall versus a plate, two different surgeries. Am I missing right there? Or they?
Well, I mean, if I'm going to do a surgery on somebody that has a posterior wall deficiency, I'm generally going to secure the plate a little bit anyway. And part of that is just construct, meaning, yeah, it may be a complete posterior wall problem, but I don't want to have to go back, and nor does the patient. So I'm right there on the plate and repairing the posterior wall. So I'm going to do the posterior wall as the main part of the repair, but I'm definitely going to secure the plate a little bit, just because over time that posterior wall deficiency, given the information that we have, 35% overlap, probably will have caused some degree of plate insufficiency. So I'm going to do both.
Okay, because I'm thinking in my head like rehab wise, because rectus versus obliques, different attachments of that of the tissue, right? The transverse abdominis attaching more to the posterior wall. I don't think it really matters, but I'm just in my head
Well,
going
no,
through.
no, but conceptually, that it's an important point. But I think that this is the conjoint tendon. So if we're looking at the plate right in the center, this is rectus coming down, adductor coming up. Conjoint tendon is the lower border of the obliques, and conjoint tendon inserts onto the plate. So
Okay,
your obliques do end up having some degree of attachment into that aponeurotic, you know.
okay. That's good. No, thank you so much. That's
Sure.
perfect. Yeah. Thanks, Tim.
Yeah, no, that's super. And you spoke about Dr. Myers, and he states in some of his articles and lectures that he gets his professional athletes back after the surgery in 4 months. Dr. Zoland, do you find that also? I mean, I'm sorry, in 4 weeks,
Right.
not months, weeks. Do you find
Right.
that also? I found that a little striking. What is your thought on that?
Um, I definitely like for people to wait longer than that. I think most of the literature about tendon to bone repairs suggests that your return to sport, your strength of that structure, is really going to take between 2 and 3 months. So that's kind of where I work it. Um, I don't like to get into this. Well, I'll get you back in 3 weeks. I'll get you back in six. For me, it's really about, let's repair the structure. Let's hope that, you really, and conceptually you can get somebody back earlier because you're depending upon the sutures to hold the structure. But if I've got a young kid and they don't need to get back to the field, I'm going to force them to wait. And the reason is I don't want to depend upon the sutures anymore. I want the sutures to hold the structure in place so that a healing process occurs between point A and point B. And that any tendon to bone healing process, by most accounts, by most research, is going to be a 3 month process. Now, listen, if you've got a professional athlete and you even though that is a truism, sometimes these athletes get back earlier than that. And I think if I do my best to push them as far as I can to do the appropriate recovery.
Hmm.
um and I think that that's like just sound medicine. But the pressures of the professional athlete are all over the place, so I do think that sometimes you do compromise that length of time.
Yes. And I was by the fact that when I saw your first post-operative patient with this, you wanted me to stretch them right away. I was like, "Well, doc, I could pull off your repair," and you were like, "No, no, no. We do this pie-crusting stuff with the adductors sometimes." And Timmy,
Right.
I want you to keep that motion and stretch them. I was flabbergasted by that. I couldn't believe that I was stretching a post-operative patient that just had a pubic plate repair back to the bone. Tell us about that.
Okay. Well, you are being a little bit dramatic. I don't want you to like stretch them. I
Yeah.
want to get a little bit. So so talking about the actual maneuver on the adductor. So we do three things during the surgery. We put the sutures to reattach the structure at the aponeurotic plate.
Hmm.
We will close the inguinal floor, thereby bringing the rectus attachment and making it a broader attachment. And then the last thing that we do is we open up the fascia to the adductor and we lengthen the adductor a little bit. So I have kind of this at odds situation with the patient in the post-op period, because on the one hand, I want this to remain completely stable. I don't want to tax it all that much. However, I have just lengthened the adductor, so I want to get a little bit of pull on that adductor so that it heals in a lengthened position rather than a contracted position. So essentially what I'm asking you guys to do is to give me some adductor work, but at the very same time, don't pull my structures off, from having just repaired it. So, and as you well know, you handle that masterfully, as most of you guys do. Um, and that's the key. Like I want them to do some adductor squeezing, but at the same time, most of the other stuff I want them to lay off of for a good month. And then after that month, we start the 2-month physical therapy protocol where we start working on initially on the chains that are not pulling into the structures. We start getting to the chains that are pulling into the structures, and then we start getting back into sport specific movement patterns.
Outstanding. Rob, another question or Don before we move to the article and then open it up for questions.
No, I think I'm good.
All right. So let's talk about this article that we're going to review a little bit tonight. And this is the Athletic Pubalgia secondary to rectus abdominis adductor longus Aponeurotic Plate injury. We talked about it tonight. They looked at 100 competitive athletes, and and they evaluated these athletes preoperatively, and they had a minimum of a 6-month follow-up, and they looked at the hip outcome score, both for regular just ADLs and also for sport-specific scores. When they got their patients back for follow-up, um, there were um, there were 85 patients that they were able to get back out of out of a total of 100 patients at 2 years. That's a pretty good follow-up. Uh, an average of 2 years, and they were allowing no pivoting or no speed training, anything to begin until week 6. That seems a little early for what we just talked about, Doctor Zoland. Would you agree with that? That's on the 5th page of the article.
Right. I think, again, I think everybody, it's broad. I mean, in some circles it's 4 weeks, in some circles it's 6 weeks, in some circles it's 8 weeks. I don't I don't take a lot of stock in the length of time afterwards.
Okay.
Generally speaking, when you talk to the PTs, when you talk to the trainers, when the surgeons say, "Oh, we get them back in 6 weeks," a lot of times it's not totally true. I mean, I had a conversation with Elliot Hirschman, who takes care of the Jets, and he was like, "Yeah, when these guys say that, there's just no way that we see that quick turnaround time."
I would tend to agree.
Yeah. So, and I don't want to throw shade towards anybody. Like I
No,
think
you're
I
not.
think some people generally get back quicker than others. Um, Again, as you well know, Tim, I'm very much on the more conservative side. Um, but all that being said, what's really interesting about the article, and specifically talking about the article, is their their catchment is purely aponeurotic plate injury. So they have already kind of screened out for any of the inguinal floor disruption component or
Okay.
insufficiency, Gilmore's groin, any occult inguinal hernias that often exist as well. Um, so they are really looking at a pure population of only aponeurotic plate injury. Not that that means anything in terms of time to return. That's still the repair that we're talking about. But he's an orthopedic surgeon, so he's not really doing all that much in terms of the inguinal canal. And the reason why I say that is because generally speaking, orthopedic surgeons do not want to go near the inguinal canal that much. They don't want to go near the spermatic cord. They don't want to deal with the ilioinguinal, iliohypogastric nerves, the genital branch of the genital femoral nerve. All of these are structures that are foreign to orthopedic surgeons because they just don't do these operations that much. On the other hand, the general surgeons do these operations all the time because we're doing inguinal hernias all the time. So we're very comfortable with that part of the anatomy. The flip side, of course, is that general surgeons don't do anything on the pubic bone. So to them, oh, sutures into the pubis, that's crazy. Why would, don't put sutures into the pubic bone? It's like, well, that doesn't make any sense. Orthopedic surgeons put sutures into bones all the time. Why should the pubic bone all of a sudden be like this sacred area where you can't put? So everybody's got their separate worlds, but this is a
Yep.
spot, and this is an injury where the worlds collide a little bit. So hence the reason why I'm operating with your orthopedic surgeons or orthopedic surgeons at HSS or NYU to do these maneuvers, because you need a
Mhm.
general surgeon and an orthopedic surgeon sometimes to kind of do the combined maneuvers.
Yeah. And you talked about the spermatic cord, and there are certain complications that we as clinicians should be on the lookout for. Can you elaborate on that? And can you elaborate on how can we screw up the surgery as clinicians, as physical therapists? What is there something that we should not do? Hey, what shouldn't we do?
Right. So I mean let's start with complications of the surgery, because I
Okay.
think that's part of what you're asking. And
Yes.
that's important. So when I talk to these young healthy people, and guys specifically, I mean, not that women can't get the injury. When we looked at the data, 15% were women, 85% were guys. I absolutely believe that that's going to get more and more equilibrated, because female sports is becoming a more equalized element. So it's not that women can't get the injury, but at the moment when we did our study about 10 years ago now, that was the breakdown. I think it's going to continue to move towards the female population, but the males have the spermatic cord, and the main point there is that the vas deferens is going through that area, and the vas deferens, of course, is the conduit that carries sperm out through ejaculation. So if you accidentally hurt either the blood supply to the testicle, which is in the spermatic cord, or you accidentally damage the vas deferens, you're talking about fertility. So hence one of the big reasons why orthopedic surgeons don't want to have
Yeah.
anything to do with this area, because we're talking about fertility in a male, and that is not something that you want to screw up. Thankfully, has never happened on one of my patients, but it could, and I do have that conversation with the patients. Now, in terms of what physical therapists can do that will damage the repair, you know, you're not going to screw up the repair irreparably, or at least I've never really seen that, just because most of you know what you're doing. Like you're well trained, you're very, very careful in the post-op patients, I have noticed. Um, and I think that, the thing is, you want to just go according to
Mhm.
this construct that the first month you want to really not pull on the attachments too much that we've just reinforced. That's where the damage would occur, theoretically speaking. And then in the second and third months, you want to have this ramp up. So the way I think of it is, if you're ramping it up 5% every week, or 10% every week, you're not going to get into too much trouble. It's when you're like skipping the ramp up, when you're going from fairly cold to fairly hot too quickly, that's when I think you're going to have the problem.
Yeah.
So to me, it's all about, and even when I talk to the patients, there's two things I tell them. I say, even though I've given your physical therapist our protocol, we wrote this protocol, if you're feeling pain that's over a 2 out of 3, you shouldn't. This isn't like a knee that's got scar tissue where the physical therapist has to break up the scar tissue. We don't want you feeling pain. And if you are, you have to give feedback. You have to say, hey, you know what? That's over a 3. Dr. Zoland said, I shouldn't be feeling anything over a 3. And the reality is that, as long as you guys are paying attention to the patient, and as long as the patient's being, you know, clear with you guys, generally speaking, that's worked out very well over the years. Um, the flip side of it is that if you have somebody who's like, okay, I know he said 3 months, but we're going to get you back in like 6 weeks, because and we're going to go really quick through this. Again, the construct is that tendon and bone repair takes 2 to 3 months. So rushing to get somebody back, and usually the truth is you guys are actually much more conservative. It's usually the patients, like I had one of the hockey players who completely tore the entire structure off. I opened him up and it was kind of like, I don't even know where I am because the anatomy is so screwed up. This thing that I've been doing for 20 years, I don't recognize because it's so screwed up. And I finally figured out where things were, and I had to pull them all back to the spots where they needed to go and anchor things back in 2.5 months. He's back on the ice playing professionally. That blew my mind in the sense that he should never have been doing that, but he did. He was
Hmm.
fine. Maybe I can be a little bit quicker in the repair, but again, or the recovery. But again, to me, that was
Yeah,
just silly.
we,
But
we've
that
talked about this.
wasn't his trainer. That wasn't. That was him. He was all about that. So, I think it's usually the patients that we have to.
Slow
That's
down.
the patients have to be you know uh kept
Doc,
in.
um, as you told me a long time ago, let pain be your guy and go from sub-maximal, ramping up to maximal. So I think that if we take that advice you gave me a long time ago, that we will do no harm and have successful outcomes. Um, let's just finish up by talking a little bit more about the article. The article, their physical therapy began day one post-op. It consisted of just decreasing pain and inflammation by stretching, walking, cryotherapy, similar to what we do. They recruit the transverse abdominal muscles early on too, by week 2. You have talked to me about not doing that at sometimes.
Right.
Um, can you have you gone away from that thought process? Are you still thinking that? Is it that like just don't recruit them maximally and pull anything off, or just I mean you got to breathe and you got to go to the bathroom, so you're
Right.
recruiting them anyway,
Ab-
So
right. Right. Just in the natural daily movements, you're using the structure. You cannot get away from using these structures that attach to the pubis. It's the very center of the human body. It's the very most central anchor point, when you have your diagonals from the ground up to your
Mhm.
shoulders, right? It has to go through the pubis. So just the aspect of walking around, just the aspect of getting up and out of a bed, you're using the structures. And if you guys want to start recruiting those structures, you know, earlier on in a very gentle fashion, I'm fine with that. It's more about when you're starting to get into real quick, hard, fast physical movements, that's where I would break with somebody who says, go at it because I fixed it. Well, yeah, you may have fixed it, but you can still damage it. So conceptually and common sense wise, why would you risk that? You know what I mean? And again,
Sure.
like to me, this is surgeon bravado, but I don't see it. I mean, I'm not a bravado guy, as you probably have known
Yeah.
over. I don't have a huge ego. I don't feel like I've got to get somebody back to the field in 6 weeks. Like I don't. There's no rush to doing that unless there really is, based upon somebody's professional. But normally, quite
Or
frankly,
the Jets are in contention for the Super Bowl championship, and we haven't had one since 1969.
oh, it's gonna happen, man. It's gonna happen. But
Hopefully our lifetime.
right, right. Maybe
Hopefully,
that
I'll see it.
will happen.
Yeah.
So, but listen, the reality is most of these players wait until the end of the season to fix them, and they have 3 months anyway. You know what I mean?
Yes.
So
Yeah, just like the Carolina Hurricane player that you did that I'm taking care of now. He had the PRP. He went all through the season, and then he
right,
did the surgery after the season was over. So
exactly.
that's the kind of timing that makes sense. Yeah.
Right. This way, we can play with the timing. We don't have to get him back to the ice in 6 weeks.
Right. We'll just finish up this article and talk about their results. Their results were pretty good according to the article. 96 of them were able to return to sport in an average time of 4 months, give or take 2 or 3 months. Um, Patients who had undergone a prior surgery were less likely to return to play, though. That's interesting. Interesting anecdote there. And
Mhm.
people that reported their hip function as normal were also less likely to return um, to their sport, um, and had a lower score on the hip outcome score with sport.
Right.
So just some different things from this article. In the discussion, I wanted to know if this is exactly what you do in your surgery. Performing fractional lengthening of the adductor longus allows excessive tension to be relieved from the tendon and muscular component, subsequently limiting uh, tendinotomy, and allows a structural layer to be turned up. So you turn that layer up also and reinforce that terminal insertion of the rectus while imbricating the injured region is and the aponeurotic plate. Is that what you do also?
I don't, I mean, technically speaking, I don't make that flap because
Okay.
to me, the flap doesn't serve any purpose. I do, everything else is pretty much the same. The common denominator with all of our different surgeries, because there are a bunch of different surgeons doing slightly different variations on the theme, but generally speaking, the common denominator is that aponeurotic plate attachment reinforcement, whether it's flipping up a flap or not, that the flap itself isn't, in my mind, of any significant value. And having done this for 20 years and having a 93% success rate,
Yeah.
I'm worried about doing a flap. But again, it's about reinforcing the structure and then lengthening the adductor a little bit. And I think most of us that do this for our careers and get good results, there's some iteration of that construct, that the reinforcement and lengthening, because this downward vector is what's pulling it off. So you not only want to fix the injury, but you want to change the vector forces a little bit for the better. So, and that's why you're
Okay.
not seeing any 17-year-olds. They've got really good, you know,
Accessibility.
elastic adductors, and as time
Yeah.
goes on, and chronically scarred, they're not as elastic, and you want to try and get them back there a little bit.
That's what I was going to ask you about. My last question about this article was in the discussion. They talked about excessive scarring. I've not seen patients with excessive scarring. Have you had patients with excessive scarring? And is there anything we can do as physical therapists once you identify that? Or do you have to go back in and take out the scar tissue?
I haven't seen,
I haven't
nor
either.
go back in to do excessive scar removal. I think, I mean, again, I don't want to speak for any other surgeons. It's
No,
not
that's fine.
but
You haven't had it.
but I do think that at the end of the day, if something's going on, calling it excessive scarring, I mean, you don't know that there's excessive scarring. There's no way to know, and so you're going to want to do an imaging study. You're going to want to see if something's not right. You're going to want to see if something has retorn. Um, but certainly, a lot of this comes down to some people heal quicker than others. A lot of times there's concomitant factors, i.e., like you had referred to, there's hip issues that overlap with the groin issues. There could be inguinal hernias that weren't taken care of because the surgeon was only concentrating on the aponeurotic plate. It could be that no matter what you do, you can't lengthen the adductor enough to decrease the vector force on the pubis, and ultimately you're forced to do a complete tenotomy. That's
Hmm.
happened a few times on my patients. So I think it's really important to, never paint something as, oh, this is excessive scarring, but try to understand what are the factors that are causing the issue at the end of the day, that's making somebody be part of that anywhere from 7 to 10% who are not doing well, and try and figure it out. If it is that the adductor is too scarred in, and no matter what you do, it's always going to be scarred in, then yeah, it's excessive scarring, and you got to do something with it.
Okay.
We had one hockey player, senior hockey player, um, who was sort of at the end of his career, and you know, he had tons of adductor pain, and yet on the imaging, there just wasn't that much to go by. But for all the world, it was at the adductor fibrocartilage insertion point. And I finally said to him, look, these are the options. He had gone through all the other options, the PRP, fractional lengthening, percutaneous tendinotomy. Um, so I said the most that I could do is take it off and put it back on. and use the anchors. And in doing so, I'm changing the vector force load because I'm putting the load now on the anchors rather than the pure fiber cartilage
Hmm.
and the tendon attachment. And he was like, Doc, if you can give me, I just want 2 more years. And next year he was on the Avalanche and they won the Stanley Cup, not
Yep.
because his surgery, but he just happened to be traded to the Avalanche and then they won the Stanley Cup. So it made me look good, of course. But at the end of the day, like, he got another 3 years out of it or 4 years out of it. He's still playing, I think. So, there are things that you could do, but you have to kind of look at it as everybody's a little bit different. Everybody's body's a little bit different. Everybody's like elasticity, as you guys well know. There's Ehlers-Danlos patients who are too elastic. I mean,
Yep.
it and the anatomy is a little bit different on everybody too. So you have to kind of take all this into account. It's not cookie cutter. Um, so can it be excessive scarring? Yeah, but you really have to look into it. You really have to like decide what you think is the issue.
I really appreciate you coming on tonight. Rob, do you have any other questions? Do we have any questions from the audience
Okay.
before we let Doc go?
We'll see about audience. I have a few. So let's see. So we noticed in this study there was lack of follow-up imaging. How often do you do if they're back and you say, okay, all good, go on, or do we know, because we know rotator cuff repairs, massive ones will fail 50%. Like, so how do we know success? How often do you image?
I mean, at the end of the day, if somebody's doing well, I don't care. I'm not going to image them. I
Right.
mean, it makes no sense, right? Just to image for two reasons, quite frankly. One is once you've done the surgery, there's a lot of artifacts, and trying to and there's a lot of what looks like scarring on the MRI. Most of it is artifact, quite frankly, and you can't at that point really go by the imaging as well as you would have if it's a virgin injury, so to speak. So doing follow-up MRIs has never been good from that point of view. But
Mhm.
unless somebody's having an issue, I'm not going to re-image them. There's just no point.
It's good. And then how often, or do you have, just we talked about, like, just since you have so much experience and you're seeing all these different people, just a plate injury, is it likely, well, that's just that, or is it so much stuff? Like, how many typical patient you'll see will have multiple?
Oh, there's a lot of just pure plate injury. I mean, I see I see 8 new patients a week, quite frankly. So it runs the gamut, but your vast majority are going to be pure plate injury. And the reason is because I'm seeing patients younger and younger these days. I mean, again, these are kids doing single sports all year long. They're pulling on that aponeurotic plate. Their structures, I mean, what we also see in these kids, in these 17 and 18-year-olds, even 19, even 20, is that they have an apophysitis, which is the growth plate at the pubis. So it may not even be that it's an aponeurotic plate injury per se, but they're getting the growth plate inflammatory process, which is due to the excessive stress on the pubis. So it's almost like a pre-plate injury type of thing. It's not a full out plate injury, but you could bet dollars to donuts if they keep doing what they're doing,
Mm.
they're going to end up having the pure aponeurotic plate injury. Um, all of that being said, when you tell, a 17-year-old who's like ranked number 5 on the East Coast for USTA, whatever, blah, 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 and you say, hey, look, this is a problem. You need to shut it down. Okay, I'll shut it down for a week. No, you need to shut it down for months. Nobody wants to hear that. The parents don't want to hear that. The player doesn't want to hear that. So you end up becoming the bad guy. And then, sometimes if they stick with you and they shut it down, they generally get better. 17-year-olds have a phenomenal ability to heal. And I'm not a big fan of going and operating. And that's the other thing. Sometimes the parents are just like, well, why don't you just operate?
Mhm.
And yeah, that's a better business model, me just operating on everybody that walks in the door. But the fact is, I'd really like them to get better on their own, because operating on a 17-year-old, operating on a 16-year-old, their plates have not sealed yet. And granted, the pelvis has probably gotten to the spot where it's going to be, but you don't know for sure if there's still going to be more growth. You don't know if you're going to screw up the growth pattern of the pelvis. So my feeling is a 16, 17, 18-year-old really should be able to heal on their own. Every once in a while, you've tried everything and then you're forced to operate. But I do my best not to. I mean, I really would rather wait until those growth plates have sealed. But pure plate injury, going back to your point, very common, very common. Not in like a 25, 29-year-old athlete, because by then it's a lot of these other things. But early on, you're seeing these pure plate injuries.
Rob, before we go, I like to tell the audience about this awesome book called Deciphering Groin and Pelvic Pain: The Interplay Between Sports Hernia, Athletic Pubalgia, and the Pelvic Floor Dysfunction. Dr. Zoland wrote it, and it is rock solid. Has a lot of great information in it. He didn't tell me to do this. I did it because I learned a ton from his book.
Well,
I have to get to my Kindle now so I can travel with it. Awesome. Great stuff. Thank you so much.
Thanks, Dr. Zoland, so much for joining us tonight.
My pleasure. Thanks, guys.